Welcome to this special episode of the NEI podcast. It's that time of year again. The 2023 NEI Congress is right around the corner. Now, whether you've already secured your spot to join us in person at the Broadmoor in Colorado Springs, or you plan to attend virtually via simulcast, or even if you're still unsure if this event is for you, you're in luck. This is our Congress preview episode. I had the opportunity to sit down with some of our brilliant faculty members who will be presenting at this year's conference for a sneak peek at their presentations and to hear more about what they're looking forward to at our 19th annual event. Listen in as I chat with Drs. Manpreet Singh, Tom Schwartz, Jeffrey Strawn, and Roger McIntyre. Stick around for the entire episode as I'll be sharing an exclusive discount code for those who have yet to register. One of the world's leading psychiatrists, Dr. Roger McIntyre, and I sat down to talk about the session he will be presenting at our pre-conference workshop on psychedelics. His session is titled Unveiling the Therapeutic Potential, Evidence Supporting the Use of Psychedelics for PTSD, SUD, and Other Indications. It's really cutting edge, and our conversation begins now. All right, well, we're here with Dr. Roger McIntyre, and we're going to be talking about one of the talks he's going to be giving at this year's Congress. And this particular talk is called Unveiling the Therapeutic Potential, Evidence Supporting the Use of Psychedelics for PTSD, SUD, and Other Indications. And so, as a quick overview, psychedelic drugs, either with or without psychotherapy, have shown to be a promising therapeutic tool for treating trauma-based disorders like PTSD and a variety of other indications like depression and substance use disorder. In this invigorating and provocative talk, Dr. Roger McIntyre will discuss the current evidence surrounding psychedelics for PTSD, SUD, and depression. This talk will give you an up-to-date understanding of the latest research in psychedelics for psychiatric disorders. Hello, Roger.
Andy, great to be with you.
Tell us a little bit about this talk and why people might want to come.
Andy, you really set it up really nice for me, and thanks for that, and great to see you and work with you, and looking forward to Congress in a very big way this year. You know, Andy, as I think about the media, the public, the scientific, really the global interest in psychedelics has only been trumped by the Eras tour by Taylor Swift, quite frankly. There's so much interest and excitement around psychedelics, and look, it's deserved. Our patients deserve hope. We deserve a new frontier, and there are some really interesting lines of research in the psychedelic area that gives us the reason to believe. I think, first of all, Andy, what I'm going to be spending some time on is definition. Psychedelic now is a tent that's so big. It began with, of course, the famous serotonergic psychedelics, LSD and psilocybin, but it's been extended out to include other mechanistically different agents like ecstasy, MDMA, and even ketamine and ketamine derivatives like esketamine. My presentation is going to focus more on the classic serotonergic psychedelics. We're going to review the data with respect to where the leads are. The best leads now are in major depressive disorder, especially TRD, treatment-resistant depression. And as you know, Andy, there's some really interesting replicated phase 3 data now with ecstasy in PTSD, which we'll certainly cover. Now, as always the case, what I'll cover, Andy, is we'll get into some of the interpretations of the data. We have to always approach data with a critical eye. And I'll go through some rather controversial topics, or at least they're controversial for now, that being how integral is the trip to the drug actually working? Relatedly, how integral is psychotherapy? Is this psychedelic assisted psychotherapy, or is this psychotherapy assisted psychedelics? I'm not sure which one it is. We'll talk more about it. Right. And then we'll also get into some of the methodology, not the boring sort of day-to-day methodology of the study, but really important things such as functional blinding and losing the integrity of blinding, and how should we interpret the data. So it's going to be a real look in a very brave way at the data, but brave in the sense of looking at some of those controversies that I think will provide a perspective for people to understand the literature. So I'll do the best, keep it up to date. It's going to be a really fun talk.
Yeah, I agree. And there are a number of strands here, if you will, to be examined. I know you have been writing quite a bit on this topic. I've really enjoyed your recent commentary on the questions around this. Is how much is the trip necessary? There's a lot of evidence in the neurobiology and the biologic mechanisms of what these drugs are doing, independent of any form of external psychotherapy or things like that. You know, these studies do have very different methodologies. I've reviewed a number of these protocols, and I'm actually the chairman of two DSMBs for these trials. So I'm aware of some of the methodologic issues that you've alluded to, but I have to agree, there is such excitement around this, and both medically, scientifically, but also in the popular press, as it should be whenever we have something new, potentially effective. And I think the concept of them working pretty rapidly is also exciting. Do you agree?
Yeah, I do. And, you know, they do work. They're rapid. They're more faster acting. They help patients with difficult to treat, very serious mental illnesses. And the opportunity to take a treatment more intermittently or sort of episodically rather than taking it every day is certainly appealing to most people. And certainly that's something that we're going to be covering. We're also going to get under the hood a little bit and look at what we think to be happening in the brain when you take these treatments. And I think really what we're going to talk about is points of convergence with conventional treatments, but also some areas that might be slightly different. And I see this as part of this new chapter, Andy. I know we've talked about this before. I think there's going to be 10, 15 years from now, we're going to look back and say, what were we thinking back in those days? Expecting patients to wait 2 months for drugs to work or 4 weeks for drugs to work, you know? So it's part of this new sort of zeitgeist in the field. But I think also, you know, Andy, I think there's a philosophical issue, which I'm going to also address in the talk. And that is, are these drugs being developed for medical purpose, or are they being developed for recreational or cosmetic or lifestyle purpose and spa purpose? And, you know, I don't think we have the luxury to be ahistorical. We've already seen peril with respect to cannabis and how cannabis was developed. It was kind of conflated medical and lifestyle. And again, I'll keep it focused on the science, less on the politics. I'll just stay in my lane on the science. But I think it's going to be important for us to really understand it. And if we wanted to use these medications medically, they have to be safe and effective, but they have to be supported by adequate and well-controlled trials. And we're going to get into some of the nuts and bolts of that.
Yeah, certainly. And if they are, when they are rolled out, I should say, there's going to be certain issues just practically for clinicians who want to incorporate this into their practice. If they are using one of these substances that does cause the trip, of course, you're going to have facilities for somebody to spend the whole day there. And what kind of staffing are you going to need? What about the scheduling and regulatory issues? You know, currently some of these are C1s, Schedule 1s. That requires a special license. And the history of that, you're right, and the politics are very interesting. You know, LSD and some of these drugs were originally developed for therapeutic purposes, and then became co-opted, if you will, by the hippies and others. And that led to a political backlash, and that's where the scheduling came in, of course. But I think that it's really fascinating, these number of different issues. But you're right that it all starts with the data. We need evidence that they work, and then we'll have to figure out how to use these tools properly. So I'm looking forward to this talk, Roger. Also, you and I will be giving a talk during the main Congress on rapid-acting antidepressants. Yeah. We won't be including the psychedelics because you'll be doing that in your other talk. So, but there's still plenty of other drugs for us to talk about.
Oh, for sure. So I'm looking forward to it. It's going to be fantastic. It'll be a lot of fun, and we're going to be, just being unvarnished with the data and try to really try to find where the data takes us and try to leave the emotion about it to the side and just let the data speak. And it's going to be a lot of fun. And look, this is a highlight of the year. This is a wonderful conference, and I'm looking forward to seeing lots of good friends and colleagues there as well.
Up next is my interview with Dr. Manpreet Singh. Manpreet and I will talk about her session titled BP1 and BP2, Diagnosing and Treating Across the Spectrum, which she will be co-presenting with Dr. Roger McIntyre. Hello, I'm Dr. Andy Cutler, Chief Medical Officer of NEI, and I'm here with my good friend Dr. Manpreet Singh to talk about the talk that she'll be giving at this year's NEI Congress. And the title of the talk is BP1 and BP2, diagnosing and treating across the spectrum. And as we know, bipolar disorders lie on a spectrum that includes both BP1 and BP2. Also, it cuts across various mood states. So it's imperative that all patients presenting with a mood disorder, especially a depressive episode, are thoroughly screened for symptoms of hypomania or mania in order to provide optimal and appropriate treatment. So in Dr. Singh's talk, she's going to be talking with Dr. Roger McIntyre, and they're going to be discussing the challenges and best practices for making a differential diagnosis of the bipolar disorders, strategies for providing evidence-based treatment that is appropriate, effective, and best suited to each individual patient's needs will also be addressed. Manpreet, tell me why you're excited about this talk.
Well, I'm super excited to join Roger and you and my friends at NEI to discuss the latest and greatest. You know, we have a lot of really neat opportunities to update clinicians about the current treatment guidelines, but also just to be able to share some very important updates on our own clinical practice. What I've learned this year in managing patients, young adults especially, who are coming in with their first episode of mania and really struggling to engage in treatment. I'm also very excited about the fact that we'll have a chance to talk about treating sleep disorders in mania in the context of insomnia, a very important transdiagnostic problem that people face across the lifespan and across disorders. So hoping to have a real opportunity, not just to share my experiences, but learn from others as well.
Absolutely. And so you're going to be doing another talk, a separate talk on insomnia. Is that correct?
Yeah, that's right. So we'll focus and hone in on this real tough challenge to manage the sleep disorders. We don't really get enough of a chance to describe the sleep problems and management of sleep in talks like the one that I'll be doing with Roger, where we focus more on overall symptoms and the management of the disorders. Frankly, there's enough there to even cover the differences between managing bipolar 1 versus bipolar 2 disorder, and the specific presentations that might, for example, confuse clinicians or create a little bit of a curveball when it comes in terms of treatment engagement. A lot of kids and adults who present with depression don't want to necessarily come and seek treatment. How do we get those people in and engaged in treatment? And how do we manage effectively when patients experience manias and they want to remain manic, for example, when actually in the long term, it's really important to mood stabilize them as soon as possible.
Yeah. Who wouldn't want a little more energy and to feel a little more confident, right? But you know, it's hard enough to diagnose bipolar disorder, but it's especially tough to recognize bipolar 2 disorder because it's so loaded with depression and hypomanias can be milder. And I guess there are some important differences as far as prognosis and even management.
Yeah, that's right. And in fact, the treatment landscape for bipolar 2 disorder is very limited compared to bipolar 1. So even though we have some tricks up our sleeves, some resources, some tools, we have work to do to really appreciate bipolar 2 disorder and figure out how to best treat it.
Yeah. And, you know, it's so important to practice evidence-based medicine. And as you've said, we do have some evidence base here, but very few FDA-approved treatments specifically for bipolar 2. But there are some that are evidence-based and reasonable. You know, Manpreet, I'm always struck by how in psychiatry, bipolar seems to be the least evidence-based treated of many of our conditions. For instance, the number one prescribed treatment for patients with bipolar, even when it's recognized, is an SSRI, which is not evidence-based.
You bet. And in fact, I would say this problem only exacerbates risk for other problems like suicide. You know, bipolar disorder is among the leading causes of death by suicide. And so we have work to do to really identify the patients that are struggling with this condition and treat them in a timely and an appropriate fashion. So the evidence base is critical. And to talk about the novel therapeutic strategies that might be on the horizon to, you know, cultivate some hope, because we really need to be hopeful that treatment landscape is on the horizon is really rich with a variety of different approaches that I think are going to be very interesting for us to talk about at the upcoming NEI Congress.
Yeah, absolutely. So I hope that you will be able to join us either in person or virtually, because it sounds like this talk is going to be highly clinically relevant and really help us with both evaluating, diagnosing, and individualizing our treatment. Manpreet, I'm really looking forward to this, and I look forward to seeing you there.
I can't wait, Andy. I'm really looking forward to seeing you and seeing all of our friends at the NEI Congress coming soon.
Dr. Tom Schwartz joins me now to discuss a really interesting topic he'll be presenting at this year's event. His session is titled Nothing Personal: Diagnosis and Treatment of Personality Disorders. Hello, I'm here today with my good friend Tom Schwartz, and we're going to be talking about his talk at this year's NEI Congress. And his talk is entitled Nothing Personal: Diagnosis and Treatment of Personality Disorders. Now, we don't get a lot of talks on personality disorders these days, and of course we know that they are highly comorbid with other psychiatric disorders, and that can increase the complexity of the diagnosis and the treatment plan. So in this presentation, Tom's going to review the diagnosis, neurobiology, and evidence-based treatment options for personality disorders, with an emphasis on borderline personality disorder, or BPD. So Tom, tell me about this talk and why you're excited to give it.
Well, Andy, maybe you've ever seen a brand new antidepressant come out, become FDA approved, and you're told it should work 70% of the time. And then in practice, it just doesn't seem to do that. How many of us just see somebody that just has depression? So over my years of practice, it's tough. People have trauma, they have personality traits, they have anxiety disorders, they have those comorbidities, and things just don't always work as advertised. So the sooner we identify personality disorder and try to treat it concomitantly, I think the better we do.
Yeah, boy, that really makes sense. Tom, I'm thinking about how many times I've started treating a patient and it's not going well, and then all of a sudden I have that dawning realization, oh my goodness, this is a personality disorder. So,
yeah, no, absolutely. Yeah, it happens.
It does. And what can we do about that? What are some tips or some takeaways maybe for the audience?
So if we could go back to the old days where, let's say as a psychiatrist, I saw patients weekly, you have more data points, right? You would pick up that diagnosis so much faster. But in the era where many psychiatrists are solely doing medication management every several weeks, you just don't get the data points. So one of the biggest things we can do is talk to the outside therapist. I don't know if we're the best group at communicating routinely, maybe the primary care physician, but the more people you talk to, you see those personality disorder patterns. And I think that's a key way to do it. There are rating scales for BPD and other disorders. So, using rating scales that are simple and easy to use. Part is detection, right? You need to make a good diagnosis, and that sets you on course to a better treatment.
Yeah, you mentioned therapist. I guess really the best treatments are longer-term psychotherapy kinds of interventions coupled with appropriate medication. Am I right?
Yeah, I think so. If you look at the evidence base and the outcomes based literature, certainly, DBT, dialectical behavioral therapy, has a ton of research. I think psychotherapy, like pharmacotherapy, has a dose and a duration. And I find, unfortunately, some of the DBT protocols are not once a week individual therapy plus once a week group therapy. And then the DBT team meets once a week. There's kind of these 3 doses for full dose DBT. And just like meds, if you don't dose it right, you may not get your outcome. So I'm a big proponent of doing it the way the book says. Psychodynamic psychotherapy, certainly can be effective. We have a researcher here at Upstate, Dr. Gregory, does something called DDP, validated form of psychotherapy, psychodynamics for borderline patients, which is pretty effective. Other psychodynamic approaches work, but I think those are the 2, maybe more than our meds, that have better outcome data.
Yeah, that's certainly true. But I think also judicious psychopharmacology, right? I mean, we want to do no harm, but also maybe intelligent use or evidence-based use of psychopharmacology can help.
Yeah, I think it's hard. What I notice with patients, either, maybe they're on one medicine or too few, we don't address their target symptoms, or they're on several, which is too many.
Yeah.
So I think judicious is, maybe somewhere in the middle. Mm-hmm. And again, you can use a categorical approach. Do they have depression? Do they have panic? Plus the personality, you can treat per the kind of the DSM, FDA approach. Or do they have a major symptom like mood lability, mood swings? It's not really bipolar, but we have meds that treat lability. And I call that a target symptom approach. And I think you got to be in the middle. Right. You can't undertreat, don't want to overtreat, but you have to take an approach and stick with it.
Boy, I love this, Tom. I mean, this is really challenging all of our skills here. What is going to be surprising to people as they come to this talk?
So, I grew up in an era where, you really weren't supposed to diagnose a personality disorder till after 18. You were supposed to see the patient for a requisite amount of time. And I think that would delay us making those diagnoses. I think a key thing is using some stringent measures, making the diagnosis sooner, and getting to the patient to, the best outcome-based treatment you can. So I do think we're going to talk about that and diagnosis and accurate diagnosis. I think like everything else, the brain's probably doing something wrong. If you have circuits in the brain that are too hyperactive or too underactive, you see symptoms on the outside. Yeah. So even though we view personality as a psychological phenomenon, there are biological underpinnings. So I think that's kind of cool to talk about too.
Yeah, I agree with you. I was taught that psychotherapy is a form of biologic treatment. In a way, you are helping to rewire the brain.
Yeah, no, I think you're right. And, is it glutamate? Is it long-term potentiation? Are you strengthening the DLPFC? Mm-hmm. Yeah, all that stuff, probably in the mix. Absolutely.
Yeah. Well, obviously, when we're talking about personality disorders, we're talking about maladaptive kinds of coping mechanisms. And I think I did a podcast, of course, with Dr. Stahl on neuroplasticity, for good or evil. I mean, not all neuroplasticity is good. You can hardwire maladaptive kinds of behaviors.
Yeah, absolutely. Yeah. And, I think somehow, we all grow up, we all have different experiences, good ones, bad ones. We all have different levels of resiliency. And, who knows why we develop the coping skills or the repetitive things that we do that get us in trouble. I view personality disorder, folks, as kind of creating an unrelenting stream of adjustment disorders. If you like that DSM term, right? It's their interpersonal conflicts puts them in stress again and again. And we know stress drives up cortisol, and cortisol shrinks the brain and makes us have less plasticity, right? It all adds up. It all makes sense to me that way.
Coming up next, faculty favorite Dr. Jeffrey Strawn and I dive into a presentation he will be giving at our Child and Adolescent Psychiatry Academy titled Along for the Ride, Treatment Considerations for Childhood Psychiatric Disorders with Co-Occurring Anxiety. Listen in. Well, hello, everybody. I am here today with my good friend, Dr. Jeffrey Strawn. We're going to be talking about his talk at this year's NEI Congress. Jeff, how you doing?
I'm doing well. How are you doing, Andy?
I'm great. Well, your talk is called Along for the Ride, Treatment Considerations for Childhood Psychiatric Disorders with Co-Occurring Anxiety. No one better to talk about this than you, my friend. Probably one of the country's, if not world's, experts on pediatric anxiety. And anxiety is common in our pediatric patients, both as a primary and a comorbid condition. And it's difficult enough to assess and treat by itself, but it can especially complicate the diagnosis and treatment when comorbid with other conditions. So, Jeff, in your talk, you're going to be exploring best practices for developing optimal treatment plans for pediatric patients with depression, bipolar, Tourette's, ADHD, substance use disorders, or brain injury with co-occurring anxiety. Boy, that's a mouthful, Jeff. Why should people come?
That is definitely a lot. So, one of the things that happens when we're treating patients with anxiety is that, as you alluded to, in and of itself, it can be difficult to treat. But oftentimes the approaches that we use when we're treating generalized or social or separation anxiety disorder become very different when we're treating those same anxiety disorders plus depression or plus ADHD. And that has a lot of implications, both in terms of the pharmacotherapy that we're using, the assessment that we're performing, and also in terms of our psychotherapeutic interventions for these kids.
Interesting. Yeah. And obviously the best outcomes are going to be combinations of these things. You know, Jeff, I know you to be not only an excellent speaker, but someone who provides both theory as well as practical takeaways. So what are some Sure. What are some practical things our audience can expect?
So one of the things that we're going to talk about is how to manage ADHD when it's co-occurring with anxiety. Yeah. And that certainly is a very common clinical scenario, at least in my practice. And I know from talking with colleagues and NEI Congress attendees over the years that they certainly encounter those same challenges. One of the things that we oftentimes don't think about is when we're treating that patient with ADHD and anxiety, and they're using a psychotherapeutic approach, we're often managing the ADHD with a stimulant. But the problem is, by the time that patient is actually getting into psychotherapy at 3 or 4 o'clock in the afternoon, that even extended release stimulant has essentially worn off. So now we're putting our colleagues who are performing the psychotherapy in a really difficult bind, in that they're relying on the patient to learn, to attend new information, to engage working memory, but they don't have that stimulant treatment on board. And that's pretty consistent with some findings that we see out of the child and adolescent multimodal anxiety study. And so we'll really spend some time talking about that and how we can optimize our treatment for both conditions to hopefully achieve better outcomes.
Yeah, I hadn't even thought of that. But, you know, also I can imagine the rebound effect sometimes that happens when the stimulant wears off. You could see irritability or agitation or spaciness, as you mentioned. Boy, that's a great example. And I can also imagine the complications when I'm dealing with anxiety and, say, bipolar disorder or substance use.
And one of the interesting things that we're going to talk about when we look at bipolar disorder with co-occurring anxiety is, first, we know that having a co-occurring anxiety disorder decreases the likelihood of remission and response in adolescents with bipolar disorder following an initial mood episode. But the other thing that we're going to actually look at, because it's been included in some of the registration trials for newer medications, is the actual impact of a primary mood disorder treatment on co-occurring anxiety symptoms. And we actually see benefit there, including benefit relative to placebo. So we'll talk a little bit about that.
Yeah. Well, you know, Jeff, you just made me realize that the top comorbidity with both ADHD and bipolar disorder is anxiety.
You're absolutely right.
So, and our treatments can complicate that. If you might be referring to atypical antipsychotics. I don't know the pediatric data as well as you do, but in the adult data for bipolar depression in particular, some of the atypicals have data that, independent of the depression, they're also improving the anxiety.
And we certainly have some of those data now in pediatric samples, certainly not as much as we do in many of the adult studies, but we do have some data there.
Great. So, you know, I guess we're going to be talking about these kind of tips with using a medication maybe to kill two birds with one stone, if you will, or to treat more than one thing, but also appropriate psychotherapeutic approaches and how to integrate those with our medication. So, boy, this sounds really practical, Jeff. It sounds like something that our audience is really going to get something out of. And, you know, I'm sure knowing you, there'll be a little bit of humor in there, a little bit of fun as well.
You'll have to wait and see.
Okay. I'm curious to see which of your wonderful bow tie collection you might be wearing as well.
Haven't decided yet, but we'll see. It'll be a good one.
As you can already tell, this year's Congress is not one to miss. I really hope you join me and thousands of your colleagues at the premier conference for Psychopharmacology Essentials. And if you can't make it out to Colorado Springs, you can always join us from the comfort of your home or office with our simulcast registration option. I invite you to use the discount code PODCAST. That's PODCAST to save an additional $100 on your registration. This code is valid on new registrations only and cannot be combined with other offers. Thanks again for joining us for this episode of the NEI Podcast.